We're going to get started with the grand rounds of today, where I am presenting an overview of the diagnosis and treatment of interstitial lung diseases. And sorry about that. And sorry. And this is part of a project that started sometime last year, where the World Center Health Program has been trying to produce some best practices articles for the diagnosis and treatment of different diseases that the program covers. So there are about, last count was about 15 articles, 14, 15 articles. There might be more. And also just as a reminder for those who have attended previous grand rounds, we presented the ones, Dr. Lowe presented the one on PTSD and trauma-related disorders. I presented the one on COPD and the one on chronic rhinitis and sinusitis. This is one. I have somebody probably lined up for substance use and substance use disorders. And there are some in review for sleep apnea and gastroesophageal reflux disease. So there's one on cancer and a smoking cessation, just so you get an overview of that. For this particular article, which is presently in review at one of the occupational journals, I work with a colleague of mine at the University of Calgary, Dr. Karen Johansson, who is an occupational pulmonologist, and also she is the director of the Interstitial Lung Disease Clinic there. So, and you will see in a second why she is also quite uniquely qualified for this particular topic. We've known each other for quite some time. So I'll advance here. The usual disclosures, the grant support that I receive, either as a principal or co-investigator, and plus additional trickles from some clinical and administrative tasks. But importantly, and that applies for all of these articles, not just this, the views expressed are not those of or do not imply an endorsement from the National Institute for Occupational Safety and Health. In this interesting series of about which, again, I'll talk some more later as they start moving through their reviews by the journal. They are intended to be brief reports, summaries, very short, about 1,000 to 1,500 word count, a dozen or so bibliographic references. There's really no research. There is an introductory, a little bit more extended article from Dr. Calvert from NIOSH, and they have been presented to a writing work group, then to the World Center Health Program Medical Forum, internally at NIOSH, and then the journal reviewers. So they really go through the ringers. So I will start with some background, and this is a chapter that pulmonologists have to learn very well to the extent possible, and is quite challenging. I'll try to underscore why in a moment. But it's ILD, as I will refer, interstitial lung diseases, is really an umbrella term, and encompasses a large and very heterogeneous group of disease entities. Depending on how you count them, there can be up to 200 diseases included in this. So you can see why it's a source of board eligible questions, because there are so many diseases with a few things in common, and many that are not in common amongst them. So But among the things that are in common about them is that they are frequently inflammatory and or fibrotic in nature. And for the purpose of this, I will assume the old terminology from medical school that fibrosis is just inflammation that is burnt out inflammation. But inflammation it is. But uh, this refers more to the active process, uh, whereas this one tends to reflect more the end product of it. But it is a continuum, and they are chronic, and many of them are progressive. A subset of ILDs is idiopathic. We know risk factors for them, but they sometimes have no clear causal relationship with the exposure. So that happens with a number of them. On the other hand, some ILDs are fairly strongly established as being causally associated with specific etiologies, and that includes environmental, occupational, and iatrogenic exposures, and as well as neoplastic and particularly connective tissue diseases. So this is something that is very important to remember when one is obtaining a history on a patient that has interstitial features and in their radiographic studies. So, okay. Yeah, there we go. So there are many ways of breaking them down. I chose a little bit the shorter one. So and you will see in a moment when the topic that I'm covering is not in the actual article. I put like a detour sign here at the bottom that I just to remind myself that that's not part of the specific overview that is in review, but I thought that for the purpose of these grand rounds that it was of a lot of interest. So anyways, there are the idiopathic interstitial lung diseases, and there is a soup of letters there: interstitial pulmonary fibrosis, non-specific interstitial pneumonitis, desquamative interstitial pneumonitis, pleuropulmonary fibroelastosis, etc. LIP, lymphocytic interstitial pneumonitis. It's like a soup of acronyms. And importantly, a fairly important, a substantial group of idiopathic ILDs are unclassifiable. Just so that, if it looks uncertain, certain cases, despite the gathering of as many expert opinions that you can imagine, still remain unclassifiable. Then there are the autoimmune disease related, and several collagen vascular diseases are associated with interstitial lung disease. Many of the majors like lupus, rheumatoid arthritis, mixed connective disease, tissue disorder. There are then the vasculitis, particularly the nuclear associated antibody associated vasculitis. Polymyositis is also associated, dermatomyositis. And then there are the exposure related, and that's why our field is heavily involved in this topic. First and foremost is hypersensitivity pneumonitis, but there are occupational interstitial lung disease. Tobacco has its own interstitial lung disease, is respiratory bronchiolitis, ILD. And then importantly, as again, exogenous agents, radiation or drug induced, and post-infectious, as COVID has taught some of us, as several of the clinicians have seen in the Celicoff clinic in particular. So all of these exposures can cause interstitial lung diseases or changes. And then there is a group of ILDs that are associated with cystic changes or with airspace filling. and that includes lymphangiomyomatosis, pulmonary alveolar proteinosis that can be associated with exposures as well, actually, and Langerhans cell histiocytosis. There's others that are way less frequent. And then sarcoidosis can be an interstitial lung disease when it involves the lung, not always. And in and of itself is its own category because of the peculiar way it presents, a very idiosyncratic. It sets it apart from the other ones, but it is considered an interstitial lung disease. And then, as usual, for most classifications like this, there's always a group of others, so the eosinophilic pneumonias, acute and chronic, and the malignancy associated ILDs. But I think if you think about the major groups like this, and that was why I was interested in presenting this, at least if you remember idiopathic, autoimmune, exposure-related, and sarcoidosis, you remember those four, you really have the majority of the ILDs covered amongst your considerations when you are trying to diagnose a patient. This one slide, I just liked it. It does, I hope it projects reasonably well, but it's kind of a good summary if one has to do it in a single slide from this particular review, very recent in Lancet, about inflammation in interstitial lung disease. There are a number of risk factors. They are, environmental, including viruses and toxicants in the occupational setting, as I mentioned, that there is, of course, an interaction with a genetic susceptibility that is not fully characterized. And there is, of course, an activated immune system that is generates a cascade of phenomena in the interstitium of the lung. So in the presence of a persistent trigger, there is the development of an infectious disease, but also towards the latter part of the process, infections and aging, the inevitable ticking of the clock, they tend to contribute to a progression from inflammation to fibrosis. And where at the beginning, we may have inflammatory interstitial lung diseases that have alveolar occupation or ground glass opacities, towards the end, you tend to see reticular, and I'll have better pictures of that, but more the fibrotic stranding and the linear densities of the typical of the fibrotic ILDs. So there is that progression in the face of a number of factors that we are beginning to understand, and some of which I will mention through this presentation. So why are they called interstitial lung diseases? Because they affect, they cause fibrosis of the interstitium of the lung. And this is a low power magnification view of the lung. And this is relatively normal lung. And that's why I chose this particular, where, a fine alveolar wall that allows gas exchange. And these are the vascular structures that expose the blood to the oxygen content of the alveoli, and then dump carbon dioxide, the basic function of the lung, the gas exchange. And you can see here the fibrotic changes that definitely tend to stiffen, the lung and cause reduced compliance. So the lungs become very stiff, very rigid, and the lung volume reduces because these are spaces that do not hold any air. You can see, from that picture, just can't picture it, and it leads to reduced gas exchange surface. So if you have all of these area available for gas exchange, of course, in an area like this, there's nothing like that. So those lead to the major or the most common functional abnormalities that we see in ILDs. And I'll refer to that further in this talk. So there are a number of patterns that are associated with ILDs. Here is a depiction of some of them. A particular pattern is called usual interstitial pneumonia, and that refers to a pathology finding that the CAT scan reflects with the fibrotic changes and the honeycombing and all of that. In the non-specific interstitial pneumonia, the fibrotic changes are less, but there are these ground glass areas that usually the UIP has less of. So you see where it's a qualitative judgment, and you see what the work of the radiologist is to try to give us some sense of what is going and qualify it and quantify it. And then organizing pneumonia is when you have the bronchial tubes filled with material, or there's consolidation in the parenchyma, which you see here. So this is a better picture of what we call usual interstitial pneumonia. When it's idiopathic, it defines a disease that we call idiopathic pulmonary fibrosis. So these two terms tend to go together, but they actually don't necessarily mean the same. This is more a pathology description, whereas in fact it was a pathologist who described it in the 1950s, Averill Liebau. And this is the disease that corresponds to this pattern when it is idiopathic. So just to give you an idea, if you have UIP, but you have an asbestos exposure history, that is asbestosis. So I wanted to kind of give you a sense of how these terms kind of connect, and unfortunately have the potential also to confuse the clinicians, but this is a pathology term, this is a clinical term. So anyways, this is the typical appearance of usual interstitial pneumonia that, as I said, in idiopathic cases is IPF. And you see mostly linear changes, right? Linear densities. There is a little bit of ground glass, and that's what we refer to areas like this, for example. There's a little bit of ground glass there and probably here. And then what happens is that it tends to be associated with these changes here that we are seeing here, that for those that might know how a honeycomb looks like, that's where the radiologist describes as honeycombing, and that is usually layers of these air-filled small cysts, and I'm wary of using the term cyst because they are not supposed to be called that way. There are also bronchioles, small airways that are dilated, and so they are called bronchiectasis. So you will see that term used by the radiologist. Some of the more proximal bronchial tubes are also pulled apart, and so that's where it can have that's why they're called traction bronchiectasis. And for some of the clinicians here, you might remember all of those terms in some of the reports for these patients. That's where they come from. In the fibrotic process, the fibrous strands start pulling at the walls of the bronchial tubes and dilate them, causing a type of bronchiectasis that is very specific to lung fibrosis called traction bronchiectasis or bronchiolectasis. And the other characteristic of UIP and IPF when idiopathic, as I said, is that it's very heterogeneous. You see areas of the lung that might look normal, and some areas that have honeycombing, and some have more linear densities, and some have more ground glass. That's typically it's almost required for this diagnosis for the radiologist to commit to this particular pattern. And it tends to involve the lower lung zones predominantly, and also be very subpleural in location. Some of the most distinct changes tend to be subpleural. Of course, the whole lung is involved, but so this is a typical picture of UIP. And unfortunately, not everything that is typical is exactly what you come across. So that's why many of these cases end up being subjected to multidisciplinary discussions to really try to come up with some understanding of what it is. So here is a pattern of non-specific interstitial pneumonitis, and you can see that it's different. It has some commonalities, but it doesn't have the extensive honeycombing. The subpleural area may be less, involved than what we saw before, and there's more ground glass than opacities, like areas, fairly extensive ground glass opacity than is usually seen in UIP. So that's where the two are distinguished. And as you can see, it's a matter of gradation. And sometimes, as I said, the matter of quite a bit of controversy amongst the specialists to try to assign to one or the other. And then this is a disease entity, another of these acronyms, DIP, disquamative interstitial pneumonitis, is distinctly associated with tobacco smoking. And also, it tends to occur in younger patients. And again, you can see how diverse, these diseases can look. There's much more ground glass changes. There's so there are some fibrotic, irregular linear densities, but there is less honeycombing. And on the other hand, these are true cysts. There are cystic changes, and this is very atypical for UIP or for NSIP. So it is a different pattern, and here, this is a smoker, but as you can see, the changes, interstitial changes, are present, but they are relatively mild. And then there are these fluffy nodules in the centrilobular location, and this is what some clinicians used to say to describe as the dirty lungs of the smokers. And but in this case, it's a little bit more structured. And this is a case of respiratory bronchiolitis, ILD, RB-ILD. So you can see here is a different pattern in usually heavy smokers. I came across one of these cases in the World Trade Center program. It was actually biopsy proven. And I think he's following up in Yonkers. He lived upstate. This disease I have never seen clinically. I've never seen a case like it, but I thought the radiology is very typical. Is the idiopathic pleural parenchymal fibroelastosis, or PPFE. And it is characterized by these pleural thickenings. And I thought of mentioning that because sometimes we get reports of biapical pleural thickening, and this is that on steroids. So definitely has more of it, much more. And it's not just confined to the apical regions of the lung, but is more extensive throughout. It's predominant in the upper and mid lung zones. And then it has these fibrotic strands very clearly seen here in this. This is a cross-sectional cut, that this is a coronal view, and where you can see that extension of those fibrotic changes into the parenchyma, and that's why the name is fairly descriptive in this case, pleural parenchymal fibroelastosis. So that's one of the categories of idiopathic interstitial lung diseases that, so I just showing a little bit of the spectrum. But going back to the unifying characteristics, ILDs are associated with a high burden of symptoms, many of them morbidity and early mortality. At present, there's really no cure for fibrotic ILDs other than lung transplantation, if we can call that a cure. While most classifications, as I said, include sarcoidosis and ILD, and the disease is covered by the World Trade Center Health Program, we actually referred to recent guidelines from 2020 and 2021 that were excellent on the diagnosis and the treatment of sarcoidosis, because it tends to be its own chapter, and it tends to be treated in a manner that differs considerably from the rest of the fibrosing ILDs. So occupational ILDs, well, being these the occupational grand rounds, of course, we wouldn't leave this without coverage. And occupational exposures have long been known to cause ILDs. Amongst the best known agents, of course, asbestos, hard metal is called, or cobalt tungsten carbide alloy, silica, and some of the hypersensitivity pneumonitis are occupational agents. So silica tends to produce more reticular nodular. It has a nodular characteristic, but it's still classified as an ILD, by the way. So those are, as I said, some of the best known examples of occupational ILD. Uh, the American Thoracic Society published in about 3 years ago a systematic review and meta-analysis that estimated that occupational exposure to vapors, gases, dust, and fumes may account for up to a quarter of what we are now still calling idiopathic pulmonary fibrosis. So this is an area of investigation as to what is the contribution of these exposures to a disease that up to now we've been calling idiopathic. The majority of ILDs, of occupational ILDs, have long latency periods, often decades, between exposures and disease manifestations. That's the majority of them. A case in point, for example, asbestos and asbestosis. Importantly, several ILDs, including idiopathic pulmonary fibrosis, are associated with cigarette smoking, and I also mentioned DIP, desquamative interstitial pneumonitis. And there's also an emerging entity about an overlap syndrome of COPD and IPF. It's very interesting. We don't get to see that very often, but it's now the true epidemiology of ILD is very difficult because there are limitations in disease ascertainment in practically all research studies. It's very difficult. So the exposure mix at the World Trade Center was never completely characterized, but most people estimate that there is at least a potential for ILD development. However, no study has established a causal link between World Trade Center exposures and pathologically and or clinically ascertained ILDs. So there was a study from the registry that was based on self-reported physician diagnosis of fibrosis, and those who are in clinic know what that can mean most of the time. So, however, further investigations are needed. They are ongoing to really try to establish that. So, what we have seen in the World Trade Center Health Program in the different cohorts, certainly I can speak for the one of which we are part of, include practically every type of interstitial lung disease that there is. So the cases that we see are connective tissue disorder associated, hypersensitivity pneumonitis, non-specific interstitial pneumonia. My 2 cases that went to lung transplant, both were NSIP. Interstitial pulmonary fibrosis, right now have a post tuberculosis fibrotic patient from Peru that is evolving at age 75 into IPF, and he's a former smoker. So we have just about every pattern of these diseases, so which makes even more difficult. And I suspect some rheumatoid lungs, and years ago I saw a mixed connective tissue disorder case. So because this is our predicament, we have to see all of them. Not all just IPF or a particular interstitial lung disease. The guidelines from the Canadian Thoracic Society position statements on fibrotic ILDs are these 3 articles, and Dr. Johansson is a lead author of one and co-author of the other 2, and that's now you would see why I called on her to work on this. They met the quality requirements for the best evidence that we were looking for clinical practice, for best practice recommendations, and because their diagnostic and treatment framework covers all these variety of fibrosing ILDs that I just described and that have been observed in our cohorts. So we have to have a broad view and not expect a single disease because we don't have single ILDs in the patients that we see. None of the cohorts has an exclusive ILD type that they see. So that guidelines start with the diagnosis and the recommendations, of course, a very detailed assessment of symptoms, potential past and establishing an inventory of potential past and present toxic occupational and environmental exposures, medications, comorbidities, and treatment for the comorbidities. And I cite that as an example. We have to know, for example, if the patient received, even if it was years ago, cancer chemotherapy, because these agents are very well known to cause ILD. So family history is always included. It's not, there tends to be some family clustering, but it's not a very strong factor, but it should be included in the past medical history. And then a very complete physical examination and complete pulmonary function test. I included bronchodilator testing because many of these patients are, particularly if they are older than 50 and they were smokers, the misdiagnosis sometimes with COPD, which is a much more common disease. And so try to do it to reach an appropriate diagnosis. So the two characteristics that I mentioned that for you to remember, what you expect to find in ILDs is these two findings. One is restriction, and I'm sure this audience has it by now very clear that restriction only means reduce total lung capacity as measured by plethysmography and lung volume assessments. So abbreviated TLC. So when you go to your complete pulmonary function test, go straight to TLC and see if it is reduced below the lower limit of normal. All right. A reduced forced vital capacity is suggestive, but you have to still corroborate it with a lung volume, a total lung capacity measurement. So if you are going to remember one thing, this is one. And the other characteristic of many ILDs is because they reduce the gas exchange surface of the lung, they cause reduced diffusion capacity. So those are the two main characteristics of ILDs that they tend to be common across most of the diseases. There are some ILDs that are associated with obstruction or that can present obstruction. I'll give you two of them. One very rare, lymphangioliomatosis, is typically associated with obstruction besides these two. And the other one is silicosis. Silicosis can give obstruction, a mixed obstructive and restrictive pattern. That said, that's more the exception, and it helps when you find it to try to narrow down your diagnosis, but ILDs are expected to cause restriction, meaning reduce total lung capacity, and reduce diffusion capacity. So in going forward with your testing, high resolution chest CT is recommended with consideration of paired expiratory and prone imaging. So ideally, this should be done when ILD is a strong consideration. So you have to really try to negotiate this in your protocol. Some places, Mount Sinai is one of them. Radiologists here say that they can use a low-dose CT scan and diagnose. We have excellent chest radiologists, so but I'm not going to get into that. Most places feel that the higher dose, high resolution chest CT is necessary. So particularly if you're going to use a facility that is not Mount Sinai, and I said that for the satellites, just go with the high resolution because you don't know how well they do low dose and how well they interpret it. And collagen vascular disease markers, your antibodies and serologies that have to really take into account some pre-test probabilities. Places like Mount Sinai that does research on ILD, they tend to do it on every ILD because they want to do a study about it, but many times there are false positives. These tests are plagued with false positive and sometimes confuse more than clarify the diagnosis. And then with the information that I just summarized, going back to it and this radiology, usually in the diagnostic processes, you go to a multidisciplinary discussion meeting. So MDD, this acronym is being used, which is a multidisciplinary discussion that usually includes a pathologist, a radiologist, a pulmonologist, sometimes a rheumatologist, and we are trying to make a case that an occupational physician should be there. So I know an article from France that is in review at a journal that I am an associate editor for, and I'm trying to push it to publication because they actually demonstrated that when an occupational physician gets involved, a substantial proportion of cases are actually ascertained as occupational. I don't remember their number. I think it was a whopping either 20 or 40% ended up. I think 40% were associated with occupational exposures, and 20% they filed for workers' compensation. I'm not belaboring that, but just so you know. And then realize that these groups, the MDD groups, they tend to review cases as more information becomes available. So it's what is described as often iterative process. So they should see the case before consideration of tissue diagnosis, but they sometimes and often have to see them again after tissue diagnosis has been obtained. So this is a case, if I remember correctly, pictures are always nice to show. That's why this is a diversion for the article with Dr. Johansson. And this was, as I remember from this article, is 37-year-old man. So that's a very relatively young person, a very typical. This is not frequently disease of young people. But it's not unheard of, as you can see here. And he does have interstitial changes, more linear densities, a fair amount of them. It's fairly homogeneous. There are some areas that are slightly different, a little bit of bronchiectasis, not quite honeycombing. You see these little um, bronchioles in cross section dilated. You shouldn't see bronchioles this large, that far out in the periphery of the lung. And this is like a traction bronchiectasis in and of itself. You can see here, like a tubular structure here. But there's no really honeycombing. So it's very atypical. In fact, it was considered inconsistent with usual interstitial pneumonia, which is the pathologic and radiologic pattern that is associated with IPF and other diseases. So, but in microscopy, believe it or not, it actually shows UIP. So that's a situation where the radiologist says, no way, it's not UIP, but the pathologist says, oh, yes, it is. And this is the normal lung, the heterogeneity that I was talking about. And then pathologists identify these foci of fibroblasts embedded like in a matrix of collagen and tissue that are called fibroblastic foci that are characteristic of UIP. So altogether, the pathology, you see here a very good case where the radiology is not consistent with UIP. No way in the world the radiologist will thumping in the table, and here's the pathologist saying, "Oh yes, it does." So it ends up being then you have to average between the two of them, and it was called possible or probable UIP because it's kind of averaging between the uh, 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 the impression of the radiologist and the impression of the pathologist. So that's why I thought that it was a very good and interesting example, although it was an unfortunate patient, 37 years of age. So uh, moving on with the diagnosis, when a confident diagnosis cannot be achieved despite an MDD, that's when lung sampling procedures may be recommended. And I wanted to mention this to you because you might think, or the patient might ask you, do I need a biopsy? Usually is after all of the radiological information, your physical findings and all of that is available. And usually you don't do it. It's done by the consulting pulmonologist. They bring it to the MDD review meeting. Manzana has one, New York Presbyterian has another one that is citywide, etc. So that's where lung sampling is considered. So transbronchial biopsy via bronchoscopy is unfortunately not very useful. It tends to work better for non-fibrotic ILDs because when they are fibrotic, all what they get is a lot of collagen. So that doesn't help, in a sample that is usually about 2 millimeters in size. It does help, however, with sarcoidosis, and that's why it is important and it still has a role to play in the diagnostic. If the consideration is sarcoidosis, transbronchial biopsy does have a place. And as you know, sometimes depending on the findings, I may tell you that try to send into our procedural pulmonologist because it is for consideration of biopsy, sarcoidosis is a strong consideration. Surgical lung biopsy these days is more often done, fortunately, with thoracoscopy. So it's a video-assisted thoracoscopy, VAT, VATS. And an emerging technique is this one called cryobiopsy, where it uses a bronchoscope, but I'll describe very briefly, at the tip of the instrument, it has a cryoprobe that freezes the tissue immediately. And then you pull both the bronchoscope and the instrument all together. And the chunks of tissue, instead of being 2 millimeters, can be up to 1 inch. Well, so you see how this procedure can have a little bit of risk of bleeding, etc., and all of that, but the sample is way bigger than what is done with transbronchial biopsy. I believe Mount Sinai is already doing cryobiopsies. I didn't have time to update myself with my colleague there, but I believe that they were implementing this. Anyways, those are the three procedures available, but they are not available everywhere. Like Dr. Johansson told me, in Canada, there are about 3 places where cryobiopsy is done. So, and the other thing that I thought that I discussed with her, being an occupational, they said, that their guideline didn't mention that mineralogic lung studies have not been integrated into the ILD diagnostic protocols, including theirs, but it really should be a consideration if available. Very few places have these laboratories. Mount Sinai has one. So it's one of the few. And in Canada, there used to be one in Vancouver where I trained for pulmonary, but actually closed. And I think there's another one in Toronto. So that just goes to say here also in the United States, there used to be one there's still one in Syracuse, upstate from us, and another one at Duke. I don't know if that's still open. So anyways, this is something that should be considered, particularly when we're looking at exposures. So this graph might be a little bit busy, but it's actually excellent in terms of illustrating the process that I mentioned. You suspect an ILD, I'll walk you through it. You do your history, physical, serologies, and CT scanning and lung function, that this module here, and that's what goes to the multidisciplinary discussion group, the MDD. So if there are clear hypersensitivity pneumonitis exposure and the CT is consistent with that, it reaches that diagnosis. On the other hand, if there are features of collagen vascular disease and also the HRCT is consistent with that, and then, you make a fairly, a firm diagnosis of connective tissue disorder, ILD. When there's no clear etiology and there's UIP in the chest CT, you might, the group might agree that that's an IPF case. When it doesn't, and the same goes for these other two when they don't, if the case is suspected to have infection or cancer or sarcoidosis, that is when transbronchial biopsy and bronchoalveolar lavage may be helpful. And again, goes back to the MDD. And whether there is a diagnosis identified or not, that's a different, But if it is not, these are not the suspicions. So transbronchial biopsy doesn't have a place. So either, you do surgical lung biopsy or cryobiopsy, but again, you go back to the MDD. And as you can see, even after going a second time to the multidisciplinary group, the disease may still be unclassifiable. So, but just to illustrate the process of how it works, and usually you don't see this, it goes into the hands of your consulting pulmonologist. So, but that's more or less how it works. So, I wanted to mention interstitial lung abnormalities as opposed to disease, because this is emerging, particularly with the widespread use of CT scans for lung cancer screening. A lot of findings, interstitial findings, are incidentally found in non-dependent areas of the lung, affecting about 5% or less of the volume of any lung zone. And they can be ground glass or linear densities, linear or reticular or linear abnormalities, lung distortion, traction bronchiectasis or bronchiectasis, honeycombing, or non-emphysematous cysts. This is the catalog of things that and this is where some of our patients come to us, I have fibrosis. No, they don't have fibrosis, or they have some fibrotic features that are now called interstitial lung abnormalities, but not disease. So we have seen them in our patient. I'll show you some data in a moment. And usually they are minimal. They are, and when they are so few of them, the chances of progression is actually very low. But when they are associated with symptoms, you have to really pay attention just to make sure that it's not an ILD that is just starting to evolve. That stands to reason. So if 3 years ago we used the ICO ERD systematic assessment of chest CTs findings. It's like an ILO, but for chest CTs, and close to 1,500 WTC workers from our Mount Sinai cohort. And sure enough, about 10% of them had either ILAs, low grade, few, rounded opacities, linear opacities, 13%, ground glass opacity, 8%, and honeycombing was much less frequent as would be expected. Usually mild, but you see here that, these happen and we have to pay attention, as to what patients to follow more closely, particularly those that have more than mild changes. So, but this is just to give you a flavor that this happens and in our own cohorts. So here are a variety of examples where you see, the arrow sign always helps you, but this is like a ground glass, right? Here, very circumscribed, very small. The same here, right? And some reticular changes. It's not quite honeycombing. Maybe honeycombing actually over here. Yeah. So just to give you that, in fact, this was considered a probable UIP. But this is what we are talking about. That they go for lung cancer screening and whoops, there's no cancer. But either way, which is good news, there are these changes that and what to do with them. So there are some changes that are not ILAs, and for example, next to osteophytes, this is an osteophyte in the spine, you see this linear density here. but that is it's caused by the presence of the osteophyte, and it doesn't relate to interstitial lung disease. So that one is excluded from that classification. The same for centrilobular nodules in heavy smokers, because that would be more like an RBILD type of situation, or they tend, when they are, very unilateral, and depending on their location, there may be a consideration of aspiration. So there are some findings that radiologists in the community might call fibrosis, and, on closer examination, actually is neither ILD nor ILA. So they, on the other hand, as I mentioned, some cases can progress, and this is an example of somebody who had some interstitial lung abnormalities. You can see them here. The arrow sign always helps. And then this was, I don't know how many years, this was 5 or 7 years. Usually takes a long time to evolve. And you can see how this is the same individual, about the same level of the CT scan, and the changes have progressed significantly, right? You see here mostly ground glass here, or there are already some reticular changes that might be evolving into honeycomb, they are not fully yet, but you see that there is, and the individual is still asymptomatic. So here you go with ILAs that may progress and still not be ILDs. So this is another example of somebody who had these changes, fibrotic changes, and underwent, I think it was surgery, either surgery, radiation, or chemotherapy. All three can cause progression of an ILD. And we had a case the other day with Candace, I believe, that had this exact situation after radiation. They had interstitial lung abnormalities before he was diagnosed with a cancer, and as far as lung cancer screening, and then underwent radiation because he was considered very high surgical risk, and then he developed radiation pneumonitis, and now he does have much more profound changes in his lung function. Quantitative CT is helping with the quantitation of these changes, because I was mentioning percentage of volume, and of course the computer can more easily determine a volume of the lung, the volume of the lung that is occupied by different types of changes. So, for example, this is the red here is mostly normal lung. The green is centrilobular emphysema. Yellow is paraseptal emphysema, which usually subpleural, and blue are the interstitial changes. And you can see how the CAT scan can calculate what the percentage of the lung is. And this is an individual who progressed from this stage to this one. So you see how it can be measured. So it's still not part of the usual techniques that we get reported. The tools are available at Manzana, but still not utilized in clinical report. You don't see it. The radiologist might be using it in the background. So again, this is a before and after, and you see a progression from 1.5% of the lung volume, these red areas here, to 4.6%, tripling in a 5-year interval. So these techniques are becoming available. Anyways, there are a number of risk factors for progressions of interstitial lung abnormalities, and this applies to what you do for your patients here in our clinic, where we have to watch them. If they smoke, they should stop, because it's a risk factors for progression of ILAs into ILDs. Certain medications, radiation therapy, thoracic surgery, and when they have physiological or gas exchange findings at the lower, very close or just below the lower limit of normal, you have to follow those people more closely. So ensure that they are the treatment program, and that they are followed closely, and we'll talk some more about that. There are a number of radiological risk factors. Non-fibrotic ILAs with basal or peripheral predominance, because they could be UIP, fibrotic ILAs with that have a probable UIP pattern. Whenever there's UIP on the horizon, that's somebody that you want to follow more closely, and that applies to my post-TB case. That eventually he did have some UIP changes, and he did evolve into UIP. He now has interstitial pulmonary fibrosis after about, he was a patient of Dr. Onoha, so you can imagine how long that was. So monitoring these patients should be seen, about 3 to 6 month intervals, with assessment of symptoms, lung function if possible. There may be a functional capacity 6-minute walk test to check for functional status and oximetry, and look for comorbidities like that tend to worsen the prognosis, like GERD, anxiety or depression, like we don't have enough of that, lung cancer, and obstructive sleep apnea. So usually you have to do a very comprehensive evaluation in the management. You try to improve all of those things to try to modify the disease progression and or mitigate it. Vaccinations, infection prevention, symptom management, treatment, and or prevention of disease worsening comorbidities, supplemental oxygen if it is necessary, and pulmonary rehab, often forgotten and neglected, and not easy to get. And then the interval for CT hasn't been determined conclusively. So in the treatment of these ILDs, there are some antifibrotic agents. We usually have to refer to, actually always have to refer to a pulmonologist that has experience with those, because these medications are not trivial. They have a number of side effects, indications. The indications are changing, they are expanding. So it has to be somebody who is up to date with those. And some of our colleagues that are involved in this field have clinical trials where some of these patients may be involved and may benefit from these agents if they prove to be of any use. Immunosuppressive medications, it is important to mention that are only used for interstitial lung disease, certainly not for IPF, but usually when there is an underlying inflammatory process like hypersensitivity pneumonitis and collagen vascular disease. So just remember these two. The other one is sarcoid. There are the three where there can be immunosuppressive agents used. I won't go through this because it's too complicated. But I just covered that. Optimal timing for lung transplantation evaluation varies. It should usually be earlier rather than later, because the evaluation by this team tends to take a long time and several weeks or months of tests. And so it takes, you do it relatively early, particularly when somebody has IPF or NSIP, because they are kind of unpredictable. They can change course, in seconds. So but in general, if the FVC, the forced vital capacity, which we can obtain very easily, is less than 80%, the diffusion capacity is less than 40%, the patient 6-minute walk, you notice that they need oxygen, or you have a sense that they have not responded to pharmacotherapy, they usually should be seen by the lung transplant team. And not to forget advanced care planning, palliative care, end of life, and the medical legal issues. We pay tribute here to something that wasn't mentioned: workers' compensation, register reporting, and other things, depending on the individual and the jurisdictions and whatever applies to them. So in general, the treatment of ILDs requires a specialized team, but general practitioners, and that's why the Canadians put out this position statement where they have very scattered centers of expertise. General practitioners and non-subspecialized pulmonologists can contribute to the adequate treatment of these patients, because there are many elements and pieces that have to be put together, and some of these situations or disease course changing episodes may come to the attention of a general practitioner or non-subspecialized pulmonologist before they come to the attention of a specialized one. So with that, I'll leave for any questions or comments that